I'm Benjamin Levy. I'm an associate professor at the Johns Hopkins School of Medicine, and I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Liquid biopsy, it sounds like could have been science fiction 5-10 years ago, but we can basically take a sample of a patient's blood with a known diagnosis of lung cancer and try to understand what the genomic underpinnings of the tumor are just by 5 to 10 cc's of blood. Essentially, this builds on the concept that lung cancer and all solid tumor malignancies for that matter will shed DNA into the bloodstream. And this is a consequence of rapidly dividing cells that then subsequently die. So apoptosis and necrosis, cells are rapidly dividing and then dying, and when they die, they basically shed out their DNA. That DNA is then detected in the blood or plasma of a patient, and we have basically apply the same technology that we do with the tissue biopsy. So that sample is sent off for next generation sequencing. And ideally, the genetic alterations that you detect in blood should be the exact same genetic alterations that you detect in the tissue. They should be the same because the DNA is coming from that tissue. Sometimes there are discordants, but 95% of the time, at least in lung cancer, if you find the genetic alteration in the plasma, you're probably going to find it in the tissue as well. What we've learned recently in lung cancer, at least in a prospective study, is that if you take patients with advanced adenocarcinoma of the lung and you do a tissue biopsy and you send that biopsy off for molecular testing, if you then add in the plasma test or the liquid biopsy test as well, you are more likely to capture the genetic alteration than you were if you were just to have done tissue alone. And the reason that is that tissue is not perfect. When we do a tissue biopsy, it's often missing the alteration because there's not enough DNA in the sample. We also know there's something called tissue heterogeneity, which is that the needle may be in one area where there is the gene of interest or in another area where there's not the gene of interest. Not every single cell in that lung mass may have the same gene, although 90% may, 10% may not, and that may be where the needle went, so you missed the gene that you then subsequently picked up in the plasma. So liquid biopsy is just another way to uncover the genomic alterations of the lung cancer, and that I generally consider using in every single one of my advanced stage patients to better capture what the alteration is. And again, it's so important to understand molecular underpinnings of tumors and the genetic alterations or the mutations. These are all the same word. Mutations, if you have them, can lead to treatment decisions that afford a patient better opportunities in terms of quality of life and longevity if they receive a targeted therapy.